Welcome everybody. Hello, my name is Carla Treloar. I'm the Director of the Centre for Social Research in Health and the Social Policy Research Centre at UNSW. I'm speaking today from the lands of the Bidjigal and Gadigal people, and over my shoulder is the beautiful Kamay Botany Bay, which is within my 5-kilometre exclusion zone for the last couple of months, and I pay respects to elders past and present, and particularly those elders who've cared for these beautiful lands and waters around Sydney that have brought me so much peace and restorative moments during these long periods of lockdown. And I extend that respect and acknowledgement to Aboriginal and Torres Strait Islander colleagues joining us on the call today. So welcome. It's terrific to see everybody here for this focus on structure and stigma in the health system. And to let you know that we are recording this, so anything you put in the chat could feature as part of the recording, including private messages to people. So we have 3 wonderful speakers today and an opportunity for engagement. So as we go through and you want to raise issues, please put them in the chat and we can come to them in that Q&A session. So I'm just going to do a brief introduction of our 3 speakers, and then I'll pass over directly so we can get straight into it because it's such a juicy topic. So our first speaker today will be Dr. Thomas Ungar, who's Psychiatrist in Chief at St Michael's Hospital and Associate Professor at the University of Toronto. So Thomas has been writing within mental health and structural stigma, and we really want to mine Thomas for everything he knows about what's happened in that field and what we can learn for the bloodborne virus and STI field. Our second speaker will be Associate Professor Fiona Haigh, who's the Director of the Health Equity Research Development Unit, which is a joint initiative between UNSW and the Sydney Local Health District. And Fiona is an equity-focused applied public health researcher. So again, we want to dig deep into what we can use about notions of equity. Our third speaker will be Sione Crawford, who's the CEO of Harm Reduction Victoria. And Sione's been working in peer-based organisations of people who use drugs since 2003. And again, our commitment in this series is to feature prominently and without fail the voices of people who are living experiences that have to deal with stigma across all parts of our health system and beyond. So it's wonderful to have Sione here as a discussant. And for those who haven't read it, Sione's paper, Shouting Through Bulletproof Glass, about experiences in the opiate substitution treatments is such a wonderful read. So if anybody needs it, I'm very happy to distribute it if you want to email me, and it really goes into that personal experience of structural stigma in that particular care system. So without further ado, I'm going to pass directly over to Thomas to take us on a journey of structural stigma in the healthcare system. Over to you, Thomas.
Thank you very much. I'm going to start my timer because I've got 20 minutes. So thank you for the invitation. Thank you, Carla, for reaching out initially, and it's really a pleasure to be speaking with you. I started my career as a family physician initially. I was doing some addiction medicine care as well, and then I returned and studied psychiatry, and have been in the world of mental health education, teaching a lot of primary care physicians for many years. And so I'll stick to what I know mostly. And what I came to realize was, despite all the education, everything I taught them, it didn't change behaviors that much. And I was quite involved in education, and I got very absorbed with the idea of transformative education, not just acquiring knowledge and facts, but changing the way something's conceptualized. And one of the things I conceptualized was the fact that the illnesses and the people suffering that I see, it is real. Not everybody thinks that. So I'm going to go through some slides very quickly and take you on my little conceptual journey of how I understand structural stigma within the mental health field. So let's hope this works. Can you see that?
Yep.
Great. So does anybody know who this person is?
Only because Sione told me earlier.
Okay, Sione told you. So when my kids were younger, because I've been using this slide for probably 20 years, and my kids are in their 20s. So it used to be the Royal Ugly Dude, and it is now, this is René Descartes. So René Descartes was again, I'm not that knowledgeable of him. He's a French philosopher in 1600s, somewhere around there. Someone else may know the date. Philosophically, he separated the idea of mind from body. And that there's a lot to that, but within my world of psychosomatic medicine, that's a significant thing, because often when we categorize a person's concerns, we consider them functional, the mind, or organic, legitimate, concrete, real. And in my hypothesis, and what's driven my work, was this fundamental divide and split between mind and body, I think has downstream impacts through the generations and throughout healthcare delivery, even in society, in the language, the concepts, the structures, how we approach care. And I don't think the people who are delivering the care or responsible for this divide, I don't think they mean ill harm. I don't think it's intentional. It's just so baked into our conceptualization. You know, you can consider it ontology, epistemology, explanatory model, cultural model, cognitive framing, whatever works for you in your field. And I think this is going to drive much of what I'm going to talk to you about. Try and forward that slide. So back in 2013, along with Stephanie Knack, we published in the Australian New Zealand Journal of Psychiatry an idea, which we called at the time the hidden medical logic of mental health stigma. And really what we did was we made this idea of this mind versus body idea, get it out there to try and see how the mental health and sometimes substance use disorders are seen as less tangible, less real, less legitimate, which leads to mostly unintentional outcomes in the structures. And how can we use knowledge of that divide to strategically design interventions, whether it's policy, service delivery, education, whatever how does that inform you in how you try to make improvements? So that's the hidden medical logic. Most recently in 2020, I was doing some sketching because there is a diagram in palliative care medicine that divides cure and comfort, where it used to be a hard divide, and they use a diagonal line to show a gradual concurrent transition of both. So what I did with some colleagues, and we published this in the Healthcare Management Forum, is did a visual to represent this instead of a hard divide between physical and mental health, and you can decide where substance use disorders fits. Can we have it concurrent? So it shouldn't be a divide. We could collaboratively, integratedly deliver care for both, fulfilling our roles based on the person's need, and all come together in a collaborative team to do that, rather than it's mine, this yours, a binomial all or none way of conceptualizing the disorders. So between Descartes' mind, body, and this diagram, this is going to tell you, this is the structural deficit that I consider fundamental. I've come to realize it's a very different way than people are using the word structural stigma and structural bias. This is the way I will use it, try to explain it for you. And hopefully it enriches and enhances and adds to those that you already use. I'm just going to skip. So one of the phenomena we see is diagnostic overshadowing. A person presents with a history of mental health or substance use. They ignore physical symptoms. They don't do the same normal care pathway. It overshadows their thinking. They make a cognitive error and they miss something, or it just denies a person access to the same care. And that can go both ways. You see disintegrated care, separate care systems in some cases, and these kind of service silos that perhaps you have. I know we have them in Canada. Okay, let's jump ahead to how it could work. So stigma is a big word. There are many types of stigma: stereotypes, prejudice, negative attitudes, labels, language, discrimination. I'm going to focus on the structure that I see the unjust policies loss and baked in institutional practices. So in the 2019 Dr. Theresa Tam, the Chief Public Health Officer of Canada's recent report addressing stigma towards a more inclusive health system, this slide was in, this visual was in there. It actually comes from the National Institutes of Health initially, and it's the Stigma Pathways to Health Outcomes model. And while what I like about it is shows how, and I would put even one step above, the cognitive idea, the structural divide in thinking cascades downscale to actual behaviors and outcomes that impact people in practices, in experiences, and in health outcomes. So I will talk about the downstream outcomes, how I see the structural stigma in my field manifesting in clinical and behavioral outcomes. So I will focus on structural stigma. In 2019, I got invited, I've been working informally, I've done some education modules with the Mental Health Commission of Canada. They have a website. If you just Google Mental Health Commission of Canada, structural stigma, All the reports are there, including this pamphlet. This is meant to fold in half. What I'm going to use is the visual in the middle. Stigma has multiple levels. The blue circle with the head is individual stigma, what a person experiences, or self-stigma, and shame, unfortunately, sometimes. The three heads in the triangle shape is interpersonal stigma, what we often think of as the social stigma, what people say and how they treat each other interpersonally. I'm not going to focus on that. The three overlapping circles, or Venn diagram, that's intersectional stigma. And that's where all the intersections of other things, gender, race, poverty, housing, everything else that would be intersectional stigmas, including structures in society, would intersect, absolutely. But I'm actually going to use the structural stigma a little differently. I'm going to focus on that institution, that building at the bottom. That's the structures, the way structural stigma manifests in the formal and informal policies, rules, procedures, laws, and cultural norms that are baked into healthcare. So that's the structural stigma I will refer to. So structural stigma refers, as Lincoln Phelan from Columbia University said, the accumulated institutional practices that work to the disadvantage of those with mental illness and substance use disorders, I would say, even in the absence of individual prejudice or discrimination. So how does this structural stigma manifest in service provision? So here's a silly little story, but I think it's symbolic. For those of you that may have heard it before, please bear with me. There's a clinic I once worked in somewhere with a hallway to see persons with mental health disorders, room A, B, and C. In room A, there's a desk, chairs, telephone, computer, and garbage can. Pretty typical for a mental health type assessment and treatment room. Some call it office, I don't know. Room B, same thing, desk, chairs, phone, computer, garbage can. Desk C, desk, chair, phone, computer, garbage can, but also has an examining table and a sink to wash your hands. Because sometimes we do certain procedures in that room for a person's health that involve needing a physical examination or a table. So the organization, the institution I worked in had to cut budget because of the pressures, which we all understand. And they decided to cut back on the housekeeping budget. And they decided to say, well, we don't need to empty garbage cans in every room, in every administrative office every day. We're going to do that once every 2 weeks in an administrative space. But of course, in a clinical space, we're going to empty the garbage every day. And the way they differentiated clinical from non-clinical was the presence of a sink. So that silly little example, you can see how in a policy, unintentionally for budget cutting, which makes total sense, they've structurally cut out the same quality of care and treatment to persons who might be coming for care with mental health and substance use disorders, or really anyone for counseling, if it doesn't involve a physical exam and having to wash your hands. Unintentional. And getting that understood was really quite challenging. And this is a silly symbolic garbage can story. This is my garbage can story. But I think you can see how it can represent the unintentional structural stigma and bias and divide, or things that can play out in care. So between Descartes' little split and this example, this is what I'm going to talk about. This is my structural divide. And this is where I focus my work now, beyond and not speaking of the individual or those other social intersections, which is not the type of structural stigma I'm thinking about. How else might it manifest? This is just showing you if people have been in hospital and discharged in my province of Ontario, how many get seen again by a physician in a week? So if you've come for heart failure, 44% get seen within a week. If you've come for COPD, that's a lung disease, about 35%. If you've come for a mental health concern, only about 28% get a follow-up. So this is a structural manifestation, a health outcome of this concept of stigma and implicit bias as it actually manifests in access and outcomes to actual healthcare delivery. That's got me excited, a reconceptualization. You can also look at money. That gets everybody's attention where I work, because of course it's stretched. You can look at the structural differences in budget. And do they correlate to the burden of illness that you're treating in your region, area, country, whatever? So in Canada, about 7% of the health budget goes to mental health care. In England, the UK, it's about 13%. In some countries, I know it's about 1.5%. I don't know for you, but that is a good example of what could be right-sized, where budgets go. And it's a manifestation of values and structural differences in funding. In the work with our group at the Mental Health Commission of Canada, I'm on the structural stigma team. We put together a framework document. This was led by Dr. Stephanie Knapp, The initial the diagram sketch was by Dr. Jamie Livingston, and this got turned into this graphic, which shows if you want to, in a bigger way, look at your organization and intervention points. This is a conceptual diagram of building supporting a stigma-free workplace, ensuring meaningful involvement of persons with lived experience, implementing stigma-informed policies, legislation, educating and training to improve attitudes and practices, measuring and monitoring equity, that's what I'll talk a bit about, adapting recovery-oriented practices, and committing to equitable resources. So a little bit of a difference, but those are still big concepts. Let me get into some nitty-gritty. So the way I have approached it is I sit at a lot of committee meetings where I look at a quality dashboard, a scorecard number, and things either hit the target or they don't hit the target. Nothing much speaks to the structural bias outcomes I've observed of mental health and substance use disorder on the dashboard. So my way of trying to implement improvement and change is to let's approach it in my world, in healthcare, as quality of care. And in the quality of care measurement world or concept, most people are using the 6 pillars of quality: safe, effective, patient-centered, timely, efficient, and equitable. They're modified in your local region. And so I thought, wouldn't the equity pillar of quality of care be a logical place to put some of it and manifest and make visible this concern and problem? In order to do that, we have to somehow measure these outcomes and monitor them. So my focus has gone from the broad concept of stigma and inequity, which of course I think we all believe in trying to intervene in, as do I think most of the healthcare providers I work with, even if I not always happy with maybe what they're manifesting, to focus on the other end, the downstream effect of actions, behaviors, performance deficits as manifestations of that structural stigma bias. And that's hard to do because what are they? You have to describe them and capture them, observe them before you can start trying to create them and bring them out. And we did a scan, and really that has not, for structural stigma, to our awareness, wasn't really yet done specifically. For stigma it was, but not for structural. In 2015 in Lancet Psychiatry with a couple of colleagues, Scott Patton and Stephanie Knack, we published this reframing that Carla so kindly called a journey, which was a big ta-da moment that, okay, I'm going to start talking about mental health stigma. It's not resonating from this stigma world into my healthcare delivery world. I'm going to reframe it in my world, and let's call it a quality of care problem. That's what people kind of understand and can go with. And we talked about it in this piece. I then challenged myself in 2017 to say, okay, big shot, nice idea. How would you do it? Well, why don't we then create items? Let's do an audit. Let's create quality measures or some kind of device. And I tend to have an idea before I know where it's going to go. So I'm not a researcher. I don't have a specific plan. I'm more a designer that has a concept and then iteratively challenges. So this was the idea. Well, let's create a health inequity audit. It could be really other pillars of quality. I started with inequity or something like that for structural stigma and implicit bias. The other members of the team are here. All their reports are on the website. There's some brilliant people, and they focus on different aspects. Heather Stewart, Jamie are doing, and Stephanie and Javid are doing persons with lived experience reports and capturing that. I'm working more on the healthcare quality measurement area, so I'll speak to that. So the first thing we did was a networking exercise, because before I start designing stuff, I want to know if there's something already out there. So we did a quick networking exercise, contacted 13 agencies across both Canada, North America, and selectively internationally. And we found out there really wasn't anything yet specific to that. The kind of things I found and people spoke of that, or I confirmed, were gaps in services related to budget, not capturing the structural stigma things within the perceptions of care that we do and satisfaction scores for persons with lived experience, policy gaps, a hidden implicit bias of quality indicators. I found narrative as a strategy very interesting for transformative learning. That's why I used the garbage can story as parallel prose. I found that to be really useful as part of a way to educate about it, because people don't really get what I'm talking about until I give that concrete example. And grouping ways to intervene could be cultural or organizational audits, or required organizational practices, performance measurement through a dashboard or indicator, equity measurement. I don't do that, but adding stratifiers. Right now, mental health and substance abuse is lumped on some things in equity audits under disability with 10 others. It doesn't pop as its own thing. And I think it may be its own health disparity that could pop in those measures. And legal, looking for a parity act. We don't have a parity act in Canada for mental health and substance use. They do in the UK and in the US. I then grouped and described a whole bunch of potential early prototypes, things that I've observed, little yellow stickies I've collected my whole career on my desk in a file under the 6 pillars of quality to try, just like the garbage can story, that the garbage can of housekeeping policies would be one of, I believe, about 72 things I listed, to then hopefully partner. Part of this had feedback from persons with lived experience, of course, but now to partner and iteratively co-design both with everyone involved in the care, persons with lived experience, people in the measurement field, people in the quality field, healthcare, admin, to then co-design which of these could turn into an actual measurable thing that if I could sneak a couple into the dashboard, we'd have success. So this is a quality dashboard at a hospital. You will see under effectiveness or under safety, the hip and knee surgery patient percentage, the harmful and critical falls, the hand hygiene compliance. This is what hospitals do and healthcare systems do. Access to care and length of stay a little bit, but nothing specific to mental health. So wouldn't it be great to have a couple of things that manifest explicitly the stigma bias that we all, I think that I see in a tangible garbage can idea. So I'll just read one out of each of the 6 and then I'll be done. So for example, under safety, the safety pillar, it would be great to have the existence and adherence to standards for evidence-based protocols to assess the medical and physical stability of persons that arrive to an emergency room, instead of very quickly making a quick cognitive bias judgment as to where they should go. So to try and take the human factor out of it, not necessarily error, but the way humans think out of it. That would be one thing to have for safety. For effectiveness, does your organization, hospital, institution, region have an evidence-based practice of a rapid access addiction medicine clinic or low barrier access to walk-in addiction service? You can't say if it doesn't show up missing on a dashboard or a tool, they don't even know it's not there. So this is step 1, and then it'll highlight and get attention. That's my hope. Under patient-centered, does your organization in their policy documents make recovery-oriented and trauma-informed care part of their mission, vision, values, etc.? We can scan for that and review that. Timely, do we measure wait times? We measure cancer, cataract, hip and knee surgeries. We don't capture or measure or have any targets for mental health and substance use treatment wait times. And if you don't hit your target in my province, funding is lost by the organization. If you hit your target, you get more funding. So there are incentives built in to do these things. And so I'm in a way hacking the quality measurement system to try and ensure better services without the person in the way. And efficient, our budget allocations, do they make sense? Equitable, is there a standalone separate health disparity identifier for mental health and substance use, especially severe mental illnesses? So other frameworks could be to use legal parity act, could be equity measurement, which is not my field. So it's important the way I'm approaching this, just as a general idea in the journey. I've shifted from educating or talking or trying to convince to trying to figure out what is important to the needs and mandates of healthcare leaders and decision makers, whatever organization and context you may work in, may be different than mine. I'm trying to look at outcomes, specific, tangible, describable things that are manifestations of this within the quality of care delivery. And I'm very aware of this whole concept of mental illness and substance use. I think it's a standalone implicit cognitive bias. It's not the one we've always talked about. And we're actually currently designing an education program with the Mental Health Commission Canada on the implicit bias of mental health and substance use disorders. It's in the demonstration phase. We're getting feedback. Hopefully the final version will be out in April of 2022. Thank you. I will stop there.
Great, so much to think about there, and I've placed into the chat, once I worked out how to drive it properly, some of those documents that Thomas is referring to. So, you know, dig deep on those, because I think that prototype work of measures, you know, that old acorn, if it doesn't get measured, it doesn't matter. And that thinking of what are the mandates that healthcare leaders, what they're judged on, what drives funding, is a really important and interesting tool for reducing structural stigma. So we're just going to jump straight over to you, Fiona, to build on this conversation and get your expertise in health equity. Over to you.
Great, thanks, Carla. Thanks, Thomas. I feel like what I'm saying is going to align perfectly with what you've been saying as well, so that's great. I'd also just like to, before I start, acknowledge the traditional owners of this land and the different lands that we're on today. I'm up in Darug and Gundagara, country up in the Blue Mountains near Sydney. And I'd like to pay my respects to elders past and present and any Aboriginal and Torres Strait Islander colleagues that we've got with us today. So in terms of where I come from, I have sort of a background in law, psychology, and a little bit of philosophy on the side. But then postgraduate studies, I moved into public health. But I've always had a really strong human rights interest in my work, and that kind of influences the way I see probably stigma and equity, which is my main area of work. And so I've got like I could describe it as a boundary spanning role where I sort of sit between health services and academia. As Carla mentioned, I'm director of the Health Equity Research Development Unit, which is a partnership between UNSW and Sydney Local Health District. And we work with the health district and other partners to really support them to think about equity and reorientate health services towards health equity. So I'm not an expert in stigma, not an expert in blood-borne viruses or other things like that. And I don't even really identify myself as a health services researcher, because my main focus is really on the determinants of health inequities, which mostly, but not entirely, sit outside health services. And I'm really interested in how we can get decision-making and planning processes to consider health equity. So when I think about stigma, there's two main aspects that really resonate with me. Is first of all, like Thomas, I think of stigma as a determinant of health in itself. So the example that Thomas gave around the diagnostic overshadowing, that we know that people who experience mental health issues die younger, not because of the mental health issue itself normally, but because the fact that they don't tend to get diagnosed and cared for chronic conditions the same way as other people. So, so stigma is itself causally powerful. And the other thing for me is stigma is an equity issue. And so when I think about inequities, those are differences which are unnecessary, they're avoidable, but they're also things that we think about as unfair and unjust. And they're not because of some kind of naturally occurring inherent characteristic of certain groups of people. It's not because people are, naughty and make bad behavioral choices. It's because of people like us, through social organizations, we decide on how resources should be distributed in society and communities. And so it's all about those multiple everyday policy and practice decisions of people in all sectors, including the health sector, those decisions about who gets what, how much, when, and where. And so stigma is an equity issue. And when I think about stigma within organizations and sort of structures of health systems, I think we have a tendency to focus on the individual, even when we're trying to think of it as at a population level. We see that in health promotion and the sort of lifestyle drift often that we see, where there's that tendency to focus on kind of educating people and telling people to eat less and exercise more, rather than thinking more about the sort of structural and environmental determinants that are shaping people's behaviours. And we see that in terms of stigma, I think, in terms of a focus often on education and training programs targeting sort of individual, like staff perceptions. But the reality is, as Thomas so clearly explained, is that those institutional practices can exist in the absence of individual prejudice, and at an organizational level, it's more than a collection of just those individual behaviors. There's something in itself at that structural level. And I think we see it at that structural level in a few different ways. Sometimes we see it in terms of there are policies and practices that are obviously stigmatizing. The example that Thomas gave as well around when you look at funding for mental health services, sort of drug and alcohol services, there's been a decision made that those services don't need to have the same level of funding as some other clinical services. And I think you also often kind of see it in terms of like the locations of those buildings and services as well, that there's been some kind of decision made about, where they are and how we access them. And we also see it sometimes in terms of, policies and rules that are meant to be non-discriminatory or non-stigmatizing, but nevertheless get applied in a stigmatizing way. So an example from the sort of blood-borne virus field, I think, is where people get asked about their status even when they're not meant to be, or kind of scheduled at the end of the day. So that's kind of someone behaving not really in line with the intended aims of those policies. But the third area that I think I'm particularly interested in is that quite often we have things that are intended to treat people equitably or equally, but they have unintended impacts that are nevertheless stigmatizing. So an example of that is, I think in health services, we're seeing increasing use of like artificial intelligence and I don't know, different sort of algorithms for picking people up who maybe are in need of particular services. So for example, identifying people who may need extra support on the basis of access and usage of health services or costs. And so that's one where they're intending to actually target people that have more need. But we also know that population groups that are stigmatized and marginalized often don't use health services to the same degree of other people. And so through that sort of measure, they don't get picked up and they don't actually access those services the way they should be. So that's kind of an unintended impact. And in terms of what do we do when we're thinking about, particularly I think those unintended type of structural drivers for stigma within the system, there are some practical tools and approaches, and some of them I'm thinking really along the same lines of what Thomas has been talking about as well. One of the main approaches that I've been involved in over the years is using tools such as health impact assessments or sort of equity lens. There's variations of them like equity-focused health impact assessments or mental wellbeing impact assessments. And the ideas of those is that they're forward-looking, and so that whenever you're developing a new sort of policy or practice or model of care, you actually, at that early planning stage, you think through what might be the potential impacts on health equity, on stigma, and you actually plan into the planning process to think about those things. So they're forward-looking, action-orientated. My experience over the years with using those tools is, although we want to have them integrated as business as usual, there can be a tendency sometimes for them to turn into tick box exercises if they're not kind of supported in a way that stops that from happening. And one of the other things I've noticed over the years with them is often the process is just as important as the outcome. So having a report about stigma impacts or equity impacts is not enough to create change. And if you often need to have a process where you're actually engaging people in the process of identifying those impacts and bringing them along on the journey. Other ways of incorporating it in that sort of organizational level is things such as Thomas was talking about, having equity dashboards, looking at patient-reported outcome measures, having disaggregation as a standard part of your reporting. So you're looking at differences in outcomes, not just in terms of outputs, because it's often at the end of the day the outcomes where we see those differences. And also linking to those existing processes and drivers like quality standards, framing things in a way that fits with the system. Sometimes that might be economic framing, linking it to things such as value-based healthcare. We've got equity frameworks within New South Wales as well. So we have a state level equity framework, and Sydney Local Health District, South East Sydney and South West Sydney all have equity frameworks. So you can kind of link these kind of actions back to these drivers. And so I think making stigma fit with the sort of business as usual framing can be really useful, but there's also some dangers in it as well sometimes. I think when we, so for example, when we frame things as an economic problem, that can often work quite well in terms of certain people are really receptive to those arguments. But by doing that, we're moving away also from that kind of moral argument, that equity argument, that human rights argument, that actually this is a thing that we should be valuing in itself and acting on, not just because it has monetary implications. But I think at the end of the day, addressing stigma within organizations, it's more than thinking about the individual people and their beliefs and behaviors, but it's also more than just thinking about the policies and the actions and the tools. So I think we need to think about it as a system as a whole, and the environment within which all those things are taking place. So thinking about health services as a kind of multi-level complex system where we want to be looking at how we can tweak the environment, which means we need to look at things such as governance, you know, and who's involved in decision making, looking inwards, you know, who's on the boards, who's at that highest level of power, how do we make those decisions, what do the decision makers look like, and kind of moving away from, sometimes I think particularly academics, we can be, depending on what field we come from, a bit naive about thinking that because we have evidence and we can identify a problem, and even if we can identify a solution, that means that it will actually create change within the system. And so, you know, we really need to think about how we can be shifting the system more as a whole, thinking about organizational culture, the who, the how, not just the what, you know, resourcing, decision making. And that means that we need lots of different people involved in these processes, you know, in terms of different disciplines, but also making sure that the people who are affected by those decisions are involved in those processes. And thinking also about how we can bring accountability for it within the systems as well. I think that's really important. I'll stop there before I go on too long. Oh, you're on mute, Carla. So over to Sione, I think.
Okay, thanks, Carla. In doing that, I lost my notes. Okay. Thanks, Thomas and Fiona. That was super interesting. And I think we're going to find that we agree. I would first like to acknowledge the custodians of the lands that I'm coming to you from today, the Wurundjeri people in the northern suburbs of Melbourne. And I'd like to acknowledge the custodians of the lands of all of the people from where everyone is coming from today. So look, I sort of started today, this morning, literally thinking I wasn't going to have enough to say, but in listening to you two in particular, I've made a few notes, so it'll be a little bit freeform, but I guess before I start, I'd say that I'm largely going to be speaking about how structural stigma manifests for people who use drugs in particular, in a range of settings, but primarily in bloodborne virus settings and AOD and harm reduction. And so naturally we'll be talking about sort of some individual circumstances, but I'd like to think hopefully they can illustrate some of the stuff that we've been talking about already. I think that, you know, as Carla said, I've been sort of interested in thinking about structural stigma and the way that it impacts on us for many years. And I guess that we were talking about how long I've been in Australia. I'm from Aotearoa originally. We were talking about how long I've been in Australia with Fiona, and I've been here 18 years. And I suppose that over that time, thinking about stigma, I've definitely seen progress around understanding of stigma discrimination for people who use drugs. But unfortunately, I think it's been mostly in the way that we talk and not in the way that we act. That's a start, which is great, which is why we're here, I suppose, as well. But I think one of the exciting things about the work that Fiona and Thomas are talking about is that we're actually really getting to the point of being able to work out how we can impact on the higher level things that impact on us as people who use drugs and who access services day to day. So I'm going to give a few examples as we go through about how that sort of operates for us on the ground, but hopefully linking it to the structural components. I'd say that, you know, just before I go into some of the individual sort of impacts, I'd say that I really have to say that I don't know if this fits right into the schemas we've been talking about, but frankly, the law for people who use drugs, the law is the thing with some of the biggest impacts, and it quite clearly still legitimizes discrimination, particularly against people who use drugs and people who are drug dealers as well, for that matter, who often are the same people. At different times through our society's history, you know, we've made certain classes of people illegal, sex workers, men who have sex with men, for instance. And we've noted over and over again that as those laws change, that stigma doesn't disappear completely, but it accelerates in its disappearance. And I would say that until frankly, politicians and actually the public who drive politicians, until they act and start to change laws, I think that I will be screaming into the wind a little bit. But it doesn't mean we can't do nothing, can't do anything. Public. And I suppose I've been involved, just really quickly, I've been involved recently, our organisation and people in it have been involved in the public intoxication law changes here in Victoria, which some of you may or may not know about, but essentially we're changing the laws so that it's no longer illegal to be intoxicated in public. And just being part of trying to disentangle that and move it from being a legal issue to a health issue is incredibly eye-opening for someone who wants drug law reform. The entrenched sort of power dynamics are incredible. So it's not a simple thing by any measure. Thinking about stigma and how it impacts on Hep C in particular, recently we've been at Haigh Victoria, we've been undertaking a peer navigation program around Hep C treatment. So this is about engaging with people who inject drugs in particular to be engaged into Hep C treatment. And we're at a point in our elimination journey for hepatitis C where we are getting to the pointy end of people who are still affected by Hep C, who are still becoming positive, and people who are not able to access treatment yet. And it's really clear how social inequity interferes and manifests in our individual priorities day to day. For many of us, finding money for drugs or food, obviously, or a bed for the night, well, I think it's obvious, is far more immediate and important than getting hepatitis C treatment. And just reflecting on on what Fiona was talking about, again, I think that we will always have a part of society, a part of our community who are not able to access healthcare as long as we've constructed basically a system that means that people feel like they need to spend 98% of their time and money on chasing down illicit drugs. And I count myself in that community, and I understand how hard it is to prioritize other aspects of our healthcare. So I mean, just that in itself means that we have to work incredibly hard to assist people with those priorities so that they can then prioritize things like hepatitis C elimination, which is frankly a bureaucratic and a sector priority, and not really necessarily a priority for individual drug users. Within that, I think another major, I think we've talked already about this, but funding inequity is a major issue, and it's not a simple issue. It manifests in different ways across the different bloodborne viruses that we work within, across HIV, hepatitis B, and hepatitis C in particular in Australia. There is a funding inequity across those diseases, and there are a lot of entrenched and important reasons for why that exists, but it does make it really tricky for us on the ground to actually to work on those issues. And within AOD and harm reduction and our approach to harm minimization in Australia, treatment and harm reduction is woefully inadequate. And as I said before, politicians and the public are ultimately culpable for this. I think I'm just going to whip through my list basically. I think diagnostic overshadowing on an individual level for us is massive in both in bloodborne virus and AOD. So we have multiple stories from individuals about how that impacts on their care, and really, I suppose you'd say both ways. So when people engage in AOD treatment and they have a mental health, co-occurring mental health issue, or if they engage in mental health care and they have an AOD, co-occurring AOD kind of issue, essentially they have two closed doors rather than two open doors still. And there is work being done in Victoria certainly to address that and to improve integrated care. But again, being involved in that, it's very clear how funding models and how schools really teaching actually impact on how we as individuals can access care in a way that's actually person-centered. And I have to laugh sometimes when we talk about person-centered care and you read a policy document or something, and really all it is a bunch of buckets of people with a stick figure in the middle. And you know, we're still literally trying to put people into buckets that actually work for bureaucracy and work for funding. And until we address that, I think, well, until we find a different way to think about that and discuss it at a policy and a political level, in particular, on a funding level, you know, it's going to be very hard to break down barriers for individuals on the ground. Look, in terms of how structural stigma really impacts on individuals, I'm going to wheel out an example I've used before, and it is in the pharmacotherapy system and not the BBB system, but they are quite linked. And I suppose this was in another state from Victoria, but a fairly small territory, and it may or may not have changed there since I left. But at the time, I was on the pharmacotherapy program, as I am now, and was on methadone, and my father had just died in New Zealand, and my mum was coming over from New Zealand to Australia to visit, and I'd taken some time off to spend some time with her, a couple of weeks, and we were going to drive around Victoria and New South Wales and just find hotels to stay in and hire a car. So I went to my doctor, who I got along with pretty well and had known for a while, and asked for 2 weeks worth of takeaways. And although he was happy to give me takeaways, he asked if he could please have some plane tickets or a hotel booking form or something to put into his paperwork, so that when he applied to the chief health officer, literally for these takeaway exemptions, you know, he'd have some evidence and that would help him out. And I said, I don't have that. We're hiring a car and we're going to just find places to stay. You know, I explained to him, you know, my mum, you know, her husband's just passed away, we're going to spend some time. And, you know, in his very well-meaning way, my GP asked me if maybe I could, in that case, get a note from, get a letter from my mother, and that he could attach to my paperwork. At the time I was 38 or 40 or something. And like I said, intentional, well-meaning, but well-intentioned, I mean, but I literally had to get a note from my mother to get takeaways, and at the age of 40. And ultimately, it's because they weren't my right. They are part of a system which prioritizes risk avoidance, I should say, and rather than sort of actual therapeutic relationships and therapeutic healthcare, I suppose. For me personally, I mean, that not only had an impact mentally, I mean, I kind of laughed about it, to be honest, but and luckily, I mean, the story is that fortunately my mother knew that I was on pharmacotherapy, and I actually got a letter from my mother. But you know, a lot of people wouldn't be able to do that. For a lot of people, that would rupture a relationship of some kind, because you've got to make a choice between telling your mother that you're on pharmacotherapy, she may or may not disapprove, or saying, no, sorry, I can't actually spend time with you. Yes, I'm a useless druggie that can't get away from my pharmacy and my drug. And given that there is a medication, that there is a system in place to avoid that, I think that's a pretty classic example of intersecting stigma, as we would say. I think, you know, if we were to take a quality of care approach, I think that, actually, before I go on to that, just quickly, diagnostic language and tools actually are something as well of a bugbear. And I think that because we as the community think about our lives, our healthcare, our dependence, if that's what it is, in a way that's, you know, much more holistic, I think, and different to the way the diagnostic tool defines us. I think that diagnostic language and diagnostic tools are things that exist to put us into containers as well, and they may be useful and valuable for care, but I think that there is a real disjunction between the language that sometimes healthcare providers speak and the language that we think about when we're talking, and that can lead to you know, even just the word disorder. I understand that it's it's a medical term, as addiction is, but as terms are used, people do start to take them on as being like a true definition of themselves, and I think we just have to be aware of that. I think that in terms of how a quality of care approach would allow services to operate differently and impact in a more positive way for people who use drugs in particular. I think Thomas's point that if we don't measure it, it doesn't exist for many services is really true in my experience anyway, at working at different levels of the healthcare system. And I think my first initial my first kind of concern is exactly as Fiona pointed out, that things can become a tick box exercise. And I think that whether that's so really the issue, well, as always with many things, it'll be about the issue will be between the intent and the implementation. And I think that for example, we currently have requirements for consumer participation to be for consumers to be involved in service reviews and planning, but in my experience, that's very inconsistently used and is very often a tick box exercise, not always. But within that, I suppose what I'd say is that if people with lived experience can contribute to and be actually involved in the planning and the implementation of bringing forth a quality of care approach to stigma, I think that's really important. But that would help with that. Would help to avoid it being a tick box exercise, but understand that first of all, we have to understand and have time and capacity and space and funding, I suppose, ultimately as organizations to get to grips with what this means, so that we can do a true co-design process. Because I think co-design is another word that has been used a lot recently and with good intent, but true co-design takes so much time, energy and engagement from everyone involved, that it's not something you can just decide to do. I think it's something you have to plan for over a big period of time. And I think that really finally the last thing that I'd say that can contribute to this in a really positive way is actually really thoughtful, planned peer programs within services. And more importantly than that even is planned organizational readiness for involving peers and services. We've seen so many times, frankly, people who with living experience and current drug use experience being involved in services that are blowing up, frankly, for everyone involved. But I think it is really important to have our voice within these processes so that we can, I suppose, speak truth to power and be supported to do that and not feel like we're going to be put into the dustbin because of that. So that's one way to sort of guard against structural stigma. Well, the approaches that Thomas talked about unwittingly being turned into tick box exercises only.
Great. Hopefully you can hear me now. I've had a complete fail on the laptop, so I'm on the phone now. Apologies for that. So fantastic, real juicy stuff to dig into. And so just looking at the chat, if we work our way down in our 7 minutes remaining, about how do we research structural stigma from Stephen. And I'll put my 30 seconds forward and other people please chime in. I think we need to do it a couple of different ways, right? There are things that Thomas mentioned that are baked into settings that we don't see because it's just the cultural wallpaper or the institutional wallpaper. So we asking people straight out, do you think structural stigma is a problem for you, might mean that their answers are informed by what they see and know, but can't be informed by what's just part of the vibe, part of the zeitgeist. So I think we need a number of ways to research or investigate, explore structural stigma. Some things are obvious and overt and people get it, and others are so sneaky or well established or just accepted that it's really hard to dismantle. And I think for me, a way I approach this is, what didn't I know about gender and has been revealed to me over my life as a lived experience as a woman, that I now understand were actually baked in structural issues around stigma that I didn't know when I was 20 or 15 or 10, but I do understand as a more mature person now. So I think a number of different ways to explore that. But please, if you've got other thoughts, jump in or put it into the chat and we can come back to you. So from Gemma, do we ever think that certain lower grade drugs such as cannabis will ever be accepted within the health community more broadly, or will this not happen until the law changes? Anyone want to jump in on that one quickly?
I'm not sure what we mean by accept. Does that mean accept as in accept as a treatment? Because I think that's ultimately, yeah, I think it's a combination of healthcare providers becoming convinced of its efficacy through evidence, but then, yeah, there's the social part of it, which is removing, I guess, in my opinion, all drugs from the legal frameworks, well, from being illegal anyway.
I mean, I think we can explore that even around medications that we have available to us and are listed as WHO essential medications like methadone, and the stigma that has stuck to that over decades, even though it's a highly effective, all the evidence is available for its impact on many domains of life. And yet, you know, it's still regularly seen in media as the wrong thing and people shouldn't be on it and all that stuff. So I think there's a big issue to deal with changes in legislation around drugs which are currently not legal, given that methadone example as a something to follow. Rob, thank you. Rob Wilkins, after Sione's story, I think we need to be cautious about blind faith in algorithms and patient-reported measures which can have baked-in blind spots and biases. Absolutely. Anything you want to add to that, Rob?
No, not really. Thanks, Sione, for that. But I think it is a growing area that is disturbing. I know with integrated care, the absolute solution a few years ago was investing in algorithms, and they were so complex, no one could actually challenge them. No one knew what was inside it. We just had to agree with it, and it had a lot of endorsement from policy people as well.
And I think we've seen various projects, including art projects, that have put forward the problems with AI, particularly in racialized ways. They're built typically by white males, and they identify others who aren't white males as all sorts of awful things. So I think AI, very interesting space for this. Thomas or Fiona, do you want to jump?
I was literally going to say, sorry, maybe Thomas and Fiona have something to say about that, but I do too. Really briefly, hopefully, which is just that we've seen the rise of technocratic solutions for what are ultimately social and I guess you'd say personal issues. Like in Victoria, we have the real-time prescription monitoring service, which ultimately is a technocratic solution for doctor shopping, which in itself, I think, often doctor shopping is a personal solution to poor healthcare, frankly. And so we've got this, we end up in this what's the opposite of it? The vicious cycle. And
virtuous.
Yeah. Well, the opposite of virtuous. Vicious. Yeah.
No, I agree with that, and that point Carla was making around who it is who's actually involved in designing and working out how these things work is really important. And even, I mean, we're talking about sort of technological advances now and AI and whatever, but it still goes back to that basic issue often of using indicators in general, like what are indicators for, and actually making sure that, what the indicators are indicating is actually what they're meant to be indicating, and having, I think, people with experience of the system and users of the system actually identifying what they might be actually demonstrating, and not just the white guys designing it.
Yeah, I'll just pick up on that because it's so true. Like, I'm not a measurement numbers person. I don't do that. I'm more a cultural observation concept person. So the fact that I'm actually advocating for this, it's not that I like them personally. It's that I see how they're used, and I'm more a designer. So I think in the design, as you just mentioned, both of you, it's in the design stage. If you can get the right input at the design stage, hopefully you can fix that before it becomes a downstream technical thing, and that's the challenge, to get that inclusion and have that done. So again, I'm not using research, I'm using sort of design methodology, which is slightly different, and that's a really different way of that I've quite enjoyed, but I know it's not quite, the evidence may not emerge till after the design's done and tested, but you have to get it at the design stage.
Yeah, and it's hard to avoid that kind of creep also then towards just valuing what is measured, so we're talking about trying to find ways of measuring things that we value, but yeah, there's often the things that we're really interested in don't easily fit into those kind of processes. And yeah, it's that whole kind of framing thing of like, they're good in terms of, yeah, they get recorded within the system, actions get taken, but by doing that, sometimes we may lose sight of other things that are just as important or more.
So we are right on 10 o'clock on our time, and there's great chat in the chat. Thanks to everyone. I love Jack Wallace's "The Stench of Stigma," being taken from China and via its influence around hepatitis into other countries, hepatitis B. Great chat from Nadia and Andy and others about that design principle of having people involved with lived experience, having them involved right in the design processes. So suck up all the wisdom of your colleagues there. It's fantastic. So I just want to say great big thanks to Thomas, Fiona and Sione for such a stimulating conversation. We have one more of these seminars left for 2021, which is a focus on lived experience. It's coming up in November. Keep your eyes out for the invitation. So thanks everyone for participating. Sorry I've had Zoom issues this morning, and hopefully we'll see you next time. But thanks again, Thomas, Fiona and Sione. Just awesome.
All right, thank you, everybody.
Thanks for inviting us.